Hi, this is Terry Kuti, founder and director of Deep Sea Foundation. Welcome to the educational YouTube channel where we talk about and discuss various topics related to breast reconstruction. I'm so happy this morning. I've had the opportunity to discuss some topics with two wonderful surgeons over in the UK. I'd like to introduce them quickly. Dr. Ruth Waters is the president-elect. These ladies are both UK-trained plastic and reconstructive surgeons. But Dr. Ruth Waters is the president-elect of the British Association of Plastic, Reconstructive, and Aesthetic Surgeons. Her partner, Dr. Dancey, is a member of the British Association of Aesthetic Plastic Surgeons and a member of the British Association of Plastic, Reconstructive, and Aesthetic Surgeons. Such a mouthful. You two are so accomplished, and I'm just so pleased to have you both back on the program this morning, and I want to welcome you both. We're going to talk about a topic today that is one of my favorite topics as a patient advocate. It's shared decision making. So Dr. Waters, I'm going to let you start this off. Welcome to both of you, by the way.
Thank you, Terry. Thank you for this opportunity to talk about this. So I've been doing breast reconstruction for about 25 years now. And one of the things that I've come to realize doing it is that breast reconstruction is not like most other surgery. It's not like here in front of us is a problem that needs to be fixed, say a hernia that needs fixing. Breast reconstruction is always complex and it's always very personal to the woman that you're doing it for. So the most important thing that you need to do is find out from that woman in front of you what it is that she's trying to achieve from it. And it was when I was at one of the American Society meetings with Anne that we listened to a presentation by yourself, Terry, and your colleagues. And it was the most impressive presentation that I attended at that meeting, and it had a huge impact on me because it said everything that I've always felt but haven't articulated as well as you do was in that presentation. Because if we as surgeons don't enable a shared decision making with our patients, we will not achieve the best that we can achieve. And it seems really in so many ways it seems so obvious. But it is also clear to me that so often that isn't what happens with women in their pathway for their breast reconstruction. And I think the focus that you put on it and the sort of direction that you can give with that is so helpful. And it's something that I've taken back to England and have not formally promoted it, but I am trying to get interest in it there and take it forward.
I'm speechless. I appreciate you mentioning the panel. I was humbled to be on that panel with another survivor and to be able to talk to the two gentlemen, Dr. Minos Chrysopoulou, who was the panel moderator, and Dr. Hani Spatani, who is out of New York now, and Kirsten Litz, the other patient advocate. It was a humbling experience, really. So I thank you for bringing it up. But you know, Dr. Waters, I really view this as such a collaborative team effort. And Dr. Dancey, I know that you too, I mean, both of you, as I call you the dynamic duo, really, over in the UK. You both use this model now, you know, in your practice.
Yeah, I've worked closely with Ruth. She was actually my consultant when I was a trainee. And the day I met Ruth, I thought, this is the woman I want to be like. because she was very different to other plastic surgeons. She genuinely cared about the patient and then making the right decision for them. And to me, that's got to be the foremost thing. There's no point in doing a reconstruction when actually that's not what the patient really wants. She wants to go home to her kids as soon as possible and spend time with the family. And so, you know, the decision should not be driven by the surgeon. This decision should be driven by the patient. I'm just there to advise, you know, what's possible, what is sensible, and then between the two of us, we have a partnership where we get the decision right. And that's very much the sort of difference between some of the kind of old-fashioned plastic surgeons who very much believe that the doctor's always right and they should tell the patient what to do, and that's that. We believe that's not the case. Everyone is an individual, everyone has different wants and needs and concerns, and it's important to address all of those. And so we've set up, I don't know if you call it the same thing in America, but we have multidisciplinary team meetings. And for me, like, there are a whole bunch of people that I work with that are really key to helping the patient make this decision. Ruth's one of them, my lymphedema nurse, and also my clinical psychologist, who I always say to patients, she's not there because you're crazy, she's there because you've got the biggest decision of your life to make. And you tend as a woman to bottle it all up for the family and you don't talk about your worries. But, you know, it's a huge implication for patients to take this on, you know, particularly when family often have their own agendas and they essentially don't want you to have surgery because they want you to be safe and well and not at any risk. So to my mind, that this is the way forward. You can't do this without them. And I felt hugely privileged to be at that talk that you did as well, because, you know, it was life-changing. It was you vocalizing what we've always believed, but never really say out loud. And I think it's so important that other plastic surgeons take this on, because it's key really to getting it right for patients, rather than ending up with an unhappy patient who we think's got a lovely reconstruction and she's just miserable. It's not what she wanted.
Yeah, I think there's so much that goes into it for both the patient and all of you as surgeons, because we're each unique as patients, not only psychologically, but also our body habitus is different. So there's just a number of things going into the consult that patients, you know, bring to the table. But then you all have to sort that out with each individual patient. But you bring up some very valid points, both of you, because this is not a one-off situation. It's not at your consult. It really goes beyond that after the healing process begins. So you kind of have to think about all of that. What do you think, Dr. Waters? I mean, if you were going to share some tips with other surgeons, what would you say are some good tips to really embrace the shared decision-making concept?
Okay, so I suppose that I think about that a lot because we have trainees and I want to impart to them not just the technical aspects of surgery or, you know, how to examine the patient, that sort of thing, but I want them to really think about what they're doing in terms of breast reconstruction. So I think the way this should go is you, as a plastic surgeon in the UK, we tend to get referred patients a little bit down the pathway. So they've already seen a breast surgeon who will have talked to them about treating the cancer, the options for treating the cancer, actually removing the tumour, whether they're going to need radiotherapy, chemotherapy, those sorts of things. They've had that discussion. And then they come to us as the plastic surgeon to discuss the reconstructive options. And I always say to my trainees, the most important thing to do is to get to know that person as an individual. Your job as a surgeon is to tell them what is possible in terms of reconstruction. It's not to tell them that this one's better than that one, because only the woman herself can decide that. For instance, you may have someone who is so frightened about the whole thing and just wants to be done with it. I've seen every extreme. I've seen women who have a cancer in one breast and they hear about radiotherapy, chemotherapy, they hear about the risks to the other breast, and they just say, look, all I want is mastectomies, and that's it, done. I don't want any of those other things. And I think it's sometimes hard for clinicians to hear a woman making a decision like that, because, you know, the radiotherapist will think, well, I could do something better for you than that, or the chemotherapist might think, you know, you could benefit from that, and the breast surgeon might think, why do you want your other breast removed? It's not necessary, and they won't understand it. But if that woman has all the information, that's the choice she makes, and then she will be comfortable with that and will be able to get on with her life with that. Equally, I see women who say, I literally cannot cope with any of this surgery or other treatment unless you tell me that I can have something there at the end of the day that makes me look okay in a bra, that means I can go swimming with my kids, that I'm not embarrassed in front of my partner. And that is my priority in this, that at the end of it, I will be able to get on with all aspects of my life again. So there's those extremes of reaction to the situation. And our job is to take the time, and however long that is, you know, and it's always going to be more than one consultation to work through that. So take the time to explain these options and get them to where they are comfortable with what you're going to do. Obviously, sometimes time is tight because they need to start treatment and get on with things. And I think that's where your shared decision-making project is so important, because it gives them the chance to prepare before the consultation, to have some information, to know that they have these choices and options, and to understand it, and to know what questions to ask, and to be able to think about what they want from the consultation with me, as well as what I want from them, before it even happens. And that it gives them that comfortable feeling that when they go into the consultation, that they've already got some knowledge, and they already got an expectation of me that I will listen and will respond to it, and get them where they want to be.
Great input. Dr. Dancey, do you feel that with the shared decision-making model, that patients are a bit more compliant, a bit more compliant in terms of their follow-up care?
Yeah, absolutely. And I particularly in the pre-op stage often use Zoom as well, where I can talk to patients. They don't feel threatened by having to come to a clinic, you know, and that creates a huge amount of anxiety for some women. Just being able to do it from their own home, and most importantly for me, to begin with, to remove the family, because certainly in England there's a lot of cultural influences, in particularly say Asians, for example, is that their family often drive their decision, not them. And to be able to give them a chance to think about what they want, and then obviously make some meaningful decision for them is important. And then certainly later on we can introduce partners and things, because they're going to have concerns and worries, and it's sometimes useful to do it lots of ways. And my clinical psychologist does that as well. And then all the information about surgery, every option, follow-up, is all on my website. So the first thing I do is send them that, let them think about it. And then they're going to buy into it, because, you know, it's very easy to, certainly we have the NHS where it's all paid for. And so patients kind of use that, but in some ways they don't really buy into the process. And they never come for follow-up. You know, I've had DEPs that have never returned, you know, and then you worry about what's happened to them. And then one of them I saw about 5 years later honestly, I swear to God, I hadn't done any touch-ups or revisions, and it was perfect. And you think sometimes maybe we should just send people away and it will fix itself. But yeah, to me that's really important, and actually to facilitate their follow-up, because if I can do some of it online, you know, bar them being seen obviously for dressing changes and wound reviews, then that's great, because they're recovering. They don't really want to make a trip to come and see me and sit in a busy clinic when they don't feel fantastic. So, and also my patients have their own support groups where, you know, it's closed, it's nothing to do with me. They can talk honestly with each other before surgery and after surgery. And I don't think in England we do that very well at all. I mean, you are a shining example of how patient advocacy should be. We do not have that system in England. It's sadly not there. And so patients are very isolated. In fact, they very rarely have their own forums and support groups for each other over there. It's just something that hasn't really been introduced to them, and that no healthcare professionals wanted to take forward. So, you know, you've sown the seeds for us to take this forward in the UK and try and make it everyone's practice, because it's so important, and we don't do the right thing for patients if we don't do it that way.
Well, I love the analogy of sowing the seeds. So I say, let's nurture this together, and let's make this beautiful garden grow for shared decision making. I have to tell you both, as we've been sitting here, maybe this is a sign. I don't know if the people can hear it in the video. I hope not. But we're getting ready to have a storm here, and it's been thundering. So we'll take that as nurturing and watering this process of shared decision making. I have so enjoyed speaking to both of you about this, and I just feel it is a concerted and universal effort. What you both brought up today is so important, and I think the fact, as a former ESL teacher, English as a second language, you brought in the fact of culture too, Dr. Dancey, and it's so important because, as you said, Dr. Waters, this is a spectrum for so many of us, both for the physician and for the patient. You know, some are extremely involved in their decision process, others not so much. And we have to learn to deal with that and to be able to, you know, nurture that broad spectrum that patients bring. So thank you both so much for joining us today. Again, I call you the dynamic duo for a reason. I appreciate your time.
Oh, thank you. Thank you very much for letting us share this with you.
Yeah, I mean, honestly, it's an absolute privilege to be able to talk to you and certainly see how things are going on the other side of the pond as well. So we very much enjoy these things, and we're more than happy to do them at any time, because I think it's really important.
Thank you. I see some more videos in the future, and I can't wait to see you both in person. We hope that's sooner than later.
Yes. Oh,
yeah, definitely.
Yeah. So thank you all for joining today. If you have any questions or comments, please let us know in the comment section. And we always appreciate it if you like the channel, and let us know if there are any other topics we can cover for you on the Deep Sea Foundation channel. Thank you both for joining us today.
Pleasure.